All right. I think enough people have joined, so we can officially start our session. So, Assalamualaikum everyone. I'm Shizra Shahid, a second year medical student at Dow Medical College. I'll be your host for today. So, I'd like to welcome you all to today's session, that is Core Principles of Diagnostic Radiology for Undergraduates session with Dr. Najeeb. Dr. Najeeb, our guest speaker for today, is a Dow alumni of batch 2002. He is currently a consultant in radiology and hybrid imaging, as well as the clinical lead for PET scans and nuclear medicine at Hull University Teaching Hospitals NHS Trust. And moreover, he also serves as honorary senior lecturer at Hull York Medical School. Apart from that, he is also a lifetime member of PWA. अब मैंने दो तीन दफ़ा मेंशन कर दिया पेशेंट्स वेलफेयर एसोसिएशन. A lot of you that are currently in the webinar might already be familiar with Patients Welfare Association, but for those of you who are new to this, I'd like to give you a brief introduction. So basically, Patients Welfare Association, it's a non-governmental, non-political, student-run organization that is run solely by the students of Dow Medical College since 1979. That is for the past 44 years approximately, alhamdulillah. It currently operates in Civil Hospital Karachi. हमारी जो है वो दो बेसिक जो है वो प्राइमरी सर्विसेज हैं, दैट इज ब्लड ट्रांसफ्यूजन सर्विसेज एंड थैलेसीमिया सर्विसेज. हमारे थैलेसीमिया सर्विसेज में वी हैव करंटली 220 रजिस्टर्ड थैलेसीमिया पेशेंट्स जिनको हम फ्री ऑफ कॉस्ट ब्लड ट्रांसफ्यूजन भी दे रहे हैं, आयरन कलेक्शन भी दे रहे हैं और बाकी सपोर्टिंग मेडिकेशन वगैरह सब कुछ दे रहे हैं. अपार्ट फ्रॉम दैट जो हमारी दूसरी सर्विस है ब्लड ट्रांसफ्यूजन सर्विस, उसमें PWA हैज अ वॉलंटरी ब्लड बैंक दैट इज पाकिस्तान लार्जेस्ट सिंगल आउटलेट ब्लड बैंक. तो इसमें बेसिकली रोज अराउंड 150 to 200 ब्लड बैग्स हम डिस्पैच करते हैं दैट मीट्स द नीड ऑफ ऑल द पेशेंट्स ऑफ सिविल हॉस्पिटल. So I hope के क्लियर हो गया होगा कि what is Patients Welfare Association. So I'd like to officially start the session. So अस्सलाम वालेकुम डॉक्टर नजीब, कैसे हैं आप?
Well, thank you very much for inviting me and organizing this. So I think better jump into it as soon as possible, really. I just want to check that you can still see my screen and the
Uh,
slideshow,
yes, your screen is visible. Slideshow is visible.
and you can see the slides moving across to the next.
Yes, we can.
Okay, thank you. So the reason why I wanted to can I just say there's a lot of echo coming back, so I'm not quite sure if somebody needs to mute. Um, that's better. So the reason why I wanted to do this session was that obviously radiology is becoming very, very important in everyday clinical care. There is a growing need for undergraduates to, to understand basic principles of radiology. And therefore, I thought it would be helpful to do a few sessions around basic radiology. Now, today's session really is an introduction to the core principles or the basic concepts around radiology practice. So this is just a very brief outline of the agenda for today. What we're going to explore is we will probably want to understand why do we need to teach radiology to our undergraduate students. Similarly, if we are going to teach them radiology, what is the scope of knowledge which is required for our undergraduates? And then we will probably try and at least discuss the basics of all the diagnostic modalities which are available. Of course, we really can't do it in very significant detail because, radiology is quite vast and it's just not possible to do everything in one session. But nevertheless, the aim would be to at least give you an introduction and just the very basics of every modality. And finally, which really I think is the crux of this presentation, which is how do we prepare our undergraduates or junior doctors to get the best radiological outcome for their patients. So I must admit that there will be a bit of an information overload, so don't get too bogged down if there's a huge amount of information coming. I mean, the bottom line is that the more I tell you, the likelihood is that the more proportion of it would just stick to your mind. So why do we really want to teach radiology to our junior doctors or our undergraduates who are soon to be junior doctors? And two essential things around that is that when you're on the wards, you're looking after your patients, particularly as house officers and or interns or whatever junior doctors are called nowadays, you are directly responsible to contribute in getting a good diagnostic image. And if it is an intervention, a good outcome in interventional radiology. Because you're on the bedside, you know a lot more about the patient. And if you understand what will happen with the patient and what is we are trying to achieve with a particular investigation, then you can contribute significantly in getting a good outcome of that exercise. Now, also in an acute setting, you probably will be the first person, to look at the more basic investigations, and that essentially means radiographs on the bedside. So, in addition to understanding the principles of how radiological images are obtained and how best to go about preparing your patients to get them done, it is important to understand some interpretation of imaging. But remember, obtaining an image comes first, looking at images comes second. So your understanding of, it may be a bit boring. You may want to see a lot of pre-pictures and want to start looking at X-rays and abdominal X-rays and chest X-rays and whatever. The bottom line is that you have to acquire these images first. And there's a huge amount of work which goes before you start looking at images. So to don't get upset if I go through a little bit of basics, because I'm sure, hopefully, in the very near future, when you're practicing medicine, you will find these informative. So, obviously, the question is how much radiology should a fresh medical graduate know? I mean, radiology is an expensive discipline. It's changing every year. Colleagues who have been practicing radiology 10 years ago are doing today what they never thought of they would be doing. So there's continuous education. And therefore, because it's such a dynamic environment, it's a little bit difficult to decide how much radiology actively we need to teach our medical students. Now, the medical education in the UK is governed by GMC, as you may know. And what they have done is that they have incorporated, in fact, in conjunction with the Royal College of Radiology, at specific components around imaging in undergraduate syllabus. And indeed, all medical graduates graduating from medical school in the UK from 2024 onwards, and any of the international medical graduates, all of them would be required to sit an exam, which is the MLA, and they will be a component of imaging included within it. So I'm not going to go into too much detail of the syllabus, but this is an introduction to what we do here in the UK. You may want to go and have a look at the curriculum, which is available online. I'm not going to go through it in any significant detail because all of it is available. And that will give you an idea or a bit of a foundation if you want to do some self-directed learning, or perhaps in the context of exams when you come towards the end of your graduate studies. So we start off by discussing very quickly why junior doctor, ward doctors, or house officers, or RMOs are an essential component of the team who contributes to good radiological practice. And so some of the reason, and this is not exhaustive, but some food for thought. When you are referring patients for investigations, obviously you need to take into account their current clinical situation, how mobile they are, do they have any allergies, are they infected, uh, do we need infection control, is there any appropriate medication history, and also what kind of comorbidities they have. And all of this feeds into, the selection of which imaging we're going to do, when we're going to do it, and the technique we're going to use. And for that to happen, you need to understand a little bit about the basic principles of a particular imaging test which is available in your institution. Why do you want to refer them? When do we need to refer them? And communication really is the key. You are the linchpin in the communication cycle between radiology, patient, relatives. You are providing that essential channel where communication is happening. So that really is very, very important. If the patient understands what is going to happen to them, they are going to be, or likely to be, able to tolerate the investigation, and indeed uh, help us while they are in the department. Similarly, some pharmacology, for example, when contrast agents are used, what medications can be used to optimize imaging. For example, in some of the GI imaging, we may use anti-motility agents, so that may need prescribing, etc. And certainly sometimes, on that's rare, but it happens. A patient might become unwell after getting contrast, or they may have extravasation of contrast, or indeed develop some sort of a renal compromise after contrast. So all of this requires management, but of course, this need, you need to understand that you need to be aware of these things. So this was more towards the management cycle which happens. Now we want to just quickly discuss some very, very generic principle of imaging, and that essentially starts what type of broad categories of imaging we have available at our disposal nowadays. And there are various ways of broadly dividing these type of investigations. So for example, we can divide them between imaging which essentially looks at morphology, then we've got imaging which looks at functions of organ, and then we've got hybrid imaging, which basically is a combination of the two. Similarly, we have got some procedures which are just single time point. It's one exposure, like a chest X-ray. And then we've got other procedures where we acquire images over a longer period of time, which is called dynamic imaging. And then, of course, you've got your various modalities, including plain radiographs, fluoroscopy, ultrasound, etc., etc. We'll cover all of this, but so what is morphological? Why do we call morphological imaging? Morphological imaging is what we are looking in terms of form and structure. We're looking at the anatomy, and this is what you regularly come across in your day-to-day practice. And this could include your plain films, your ultrasound, your CT and MRI. Most of the time, this is a representation of a single time point. When you press the button on your X-ray machine, what does that part of the body looks like? So then we've got functional imaging. Functional imaging is where you're assessing function or physiology, and representing them in the form of images. Most of the time, that refers to nuclear medicine, where we have got conventional nuclear medicine, for example, bone scans, and renograms, but also the more cutting edge, right, CT imaging. Now, Functional imaging is not limited to nuclear medicine. There are other modalities which have got their own functional components. So, for example, MR has got diffusion weighted sequences, which also look at function. You can do a lot of functional or physiological imaging with CT. For example, you can look at the coronary flow reserve and things. Um, Sometimes, a lot of time, in fact, functional imaging is a dynamic activation. If you want to see something functioning or physiology, you have to probably more than often take a few images to see how things are progressing. So this is really the fundamentals of the two broad categories of how we image human body. Dynamic imaging is again most of the time we're trying to assess function. So there are imaging at multiple time points. It does provide a lot more information. Why do you need to be aware of dynamic imaging? Is that if you know that the procedure is categorized or likely to be an examination, what we call dynamic, then it will require more time. And subsequently, of course, the patient would need to be more compliant. And so, in everyday clinical practice, that will equate to somebody who is comfortable. So, for example, not in pain. And if they are in pain, they require pain relief before they actually come to the examination. I cannot tell you how many times we lose slots in radiology and nuclear medicine, whereby the patient comes, for example, for a ward and they have not got adequate pain relief, and therefore they can't be compliant with with what we're going to do, and they have to be taken back. And so, just to draw your attention to these, practical bits, which because you're based on the wards, you are going to be in a position to um, influence and be beneficial for everyone, including yourself, because radiology, remember, is a resource. If you're not going to use the resource appropriately, then you might not find another slot. And essentially, you're going to struggle to find, get your patient's image. So dynamic imaging, every modality by and large can be used to do dynamic imaging, and MR, ultrasound, nuclear medicine, fluoroscopy, all of these. Before we go on to discussing some modalities, it is important to just very, very briefly, and I say very, very briefly with a lot of emphasis, because don't get, sleepy, because there's not going to be a lot of physics involved. So I'm going to only touch base of very basic things. And one of that is, when we are imaging patients, we are using radiation in some of the modalities. So it's very, very important to understand the difference between ionizing and non-ionizing radiation. Non-ionizing radiation is essentially which does not pose as much a health risk to patients by and large. It can if you expose them for too long, but nevertheless, for the purpose of imaging, what we need to be aware of, which modalities are ionizing radiation, because those are the ones where there is a risk for patients, both in terms of direct injury as well as long term, because ionizing radiation is called ionizing radiation because it removes electrons from molecules, and that can lead to pre-malignant or malignant conditions if given enough time. So safety, of course, is really important for patient, and patient protection is, at the core of practicing radiology. What you shouldn't do is cause harm to patients. So in order to be safe, you need to understand the basic principle, which is that ionizing radiation, any exposure to that is significantly regulated, and you need to engage with that regulatory process so that patients are not exposed to this type of radiation without due consideration of risk versus benefit. Also remember that ionizing radiation is particularly problematic the younger the patient is. Your 90-year-old patient's risk of developing a malignancy because of exposure to diagnostic imaging is much lower than your very, very young patient. The younger the patient, the more time they have to, cause the mutations induced by ionizing radiation to end up in malignancy. That is particularly important for patients like, female patients, because they are pregnant and nobody knows about it and they are exposed to ionizing radiation in perhaps the first 3 months. And that is a major problem for the fetus. But obviously, even adult patients are not, um, completely immune to developing. So we've got two examples here. You've got a CT. The CT. Let me see if I can. The patient has had a breast malignancy and they've got a breast prosthesis here, but subsequently they've developed radiation-induced sarcoma, or soft tissue sarcoma, which is not infrequent in patients who are treated with radiotherapy, but nevertheless, it's just a mechanism of alerting you to the possibility that radiation can cause problems. Similarly, this is a type of a study which can cause palpitations. You can see the patient has been exposed, possibly inadvertently, and there's a fetus visible in this abdominal radiograph, which should only happen in very, very extreme situations. It should not be done. So yeah, importance of the basic safety, and you are responsible as the referrer or people who are on the bedside to help radiology ensure that the practice is safe. So we're going to move on to some modalities very quickly. I'm going to cover the basic principles of the most important modalities. Not going to go into significant details because of just time constraints. And again, the aim is to provide you with some very, very basic foundation of perhaps not only learning but also sort of get you interested to go and do some reading and try to broaden your understanding based on these principles. So we'll start off with everybody's favorite plain X-ray or plain radiography. This involves ionizing radiation, where X-rays are produced by the machine. Patient is stood close to the film, and then the image is generated based on the fact that how many of these X-rays are stopped by the body. And something of this description will appear on the screen. And I think, strictly speaking, if we are looking at one thing which I want you all to take from this, we can't remember anything tomorrow from whatever the ramblings I'm doing. Just remember this one slide, which really is a cornerstone of understanding how images are obtained, but also feeds into how we actually interpret images. So if you understand how images are produced, you will be in a much better position to look at them on the bedside and identify pathology. So, and this radiographic densities, the 5 basic radiographic densities underpin this concept. So the 5 radiographic densities are air, which does not really stop X-rays at all, and so that part which contains air is very much black, as here, because all the X-rays coming hit this film and produce a black component on the film. The second density is fat, which attenuates or stops the X-rays to a certain extent, a bit more than air, so they are a bit less black. And then you got water density, which is slightly better at stopping X-rays than fat. And then you've got, the water density is also equates to soft tissue density for the purpose of clinical images. And then we've got bone, and finally metal. And as you can see the cascade, the more dense the object is, the more X-ray is going to stop and the more whiter it will look. And that is again demonstrated on this, nice image. And this really goes back to when radiology was evolving as a discipline. And I think this paper was from 1977, I think. Yeah. How does it actually then feed into the image you are looking at? And then here is an example of a chest X-ray. All the five densities are visible on this. So let's start with air. Your lungs contain air. So wherever there is good aeration of the lungs, you will find that the area is black. Wherever there is less aeration, you will find that it turns white. Regardless of why there is less aeration, fluid or cancer or pneumonia, doesn't matter. No air, you know, you will know there is pathology. Then perhaps you've got some fat density here in the right supraclavicular area. The third density is water density, and that is primarily soft tissue density. And you can see here in the cardiac stylohead, and perhaps, just below the diaphragm and some of the soft tissue around the musculature. Then we have got bones, and I don't need to introduce you to bones. And finally, we have got on this radiograph metal. So you can see all five densities are visible. That really is important to understand this. So if again, sort of might sound like a broken record, but if you can't remember anything from today, just remember this. And finally, what happens is whenever there is an interface between two densities, for example, here, you've got the cardiac border, the right heart border, you've got air containing lung. Wherever there is an intersection between two densities, that is where you've got resolution on your image. And therefore, the normal appearances are dictated by wherever there is an interface. So for example, below the diaphragm, you can't really see much on this chest X-ray because it's entirely soft tissue. So you cannot really differentiate if you've got two densities of a similar attenuation characteristic lying adjacent to each other. You can't differentiate between the two. And so wherever there is an interface, you can identify that structure. If that interface is lost, for example, in pathology, for example, if there's a big consolidation here in the lungs, you will lose that heart border because there will be similar attenuation structures adjacent to each other. And therefore, you can't really identify the heart border because you've lost that interface with air. Similarly, if something destroys that rib, you can't really see that nice margin of the rib because that interface between the rib surface and the lungs is lost. So, in summary, understanding the five basic radiographic densities is the core principle of starting to understand how images are obtained and subsequently interpreted. Finally, another couple of lessons. So this is an interesting image. Let's deal with this first. These are two eggs. Both have got similar characteristics, but the positioning of the patient is very important. So this egg is lying in profile. This egg is lying or standing up in front of you. So This has got more density because there is more material. So if we image them from here, there will be more material from A to B, and if there's a film here, there is a source of X-ray, there will be more material to stop the X-rays reaching this film. So the density will change depending on the position of the patient. If you go to the left side of the screen, you will see that same patient. Again, what has happened here is they would develop pleural effusion. The reason why you can see that effusion is that, here we've got air-filled lung, you've got a nice border because you've got an interface. That interface is lost here, so you lost the hard border. Then you've lost the hemidiaphragm because you've got very similar density accumulating here. But if you put the patient in a decubitus position, right, from the right side, you will see that you can get the fluid to move and the configuration of the fluid changes. And that is important in some types of investigations whereby positioning becomes much more important. So if you, for example, if you image this patient lying down, all of the fluid will start accumulating along the dependent part. I mean, basically, you might not even see a pleural effusion because when the patient is lying flat, the fluid will be accumulating across the posterior aspect of the lung in profile, and you can't really see that edge developing. So radiographic densities, and on the basis of that, the positioning of the patient is particularly important. And before you start looking at an image on the bedside, you need to understand how the images look. If the patient was able to stand, was they able to get a good breath in? For example, some patients can't really take a deep breath in. The problem then is that the air does not fill the lung appropriately. So that important characteristic of having a different type of attenuation material outlining becomes a bit of a problem. But everything boils down to these five radiographic densities. So I hope you will be able to ingrain it into your mind and always look at imaging. And remember that is not only on plain films. Some of the other modalities also work on the same principle. Very briefly, we'll touch upon fluoroscopy. This is the equipment, which is basically a glorified X-ray machine, but basically provides a couch and you've got a C-arm. Essentially provides a live X-ray environment. So you can visualize what is happening in the patient in sort of plain films, but at a touch of a button, you can see a video or a cine of what is going on. So primarily, this is a lot of it is done for interventional procedures where you need to look at what you're doing. Surgery, for example, orthopedics. But there are some diagnostic investigations which are still being done on fluoroscopy, and one of them is barium swallow or contrast swallow, where the patient takes a sip of the contrast, then drinks it in front of the machine, and you can basically identify the whole course of how that contrast is ending up in the stomach, but also look at the dynamic function of the esophagus and certainly the upper aerodigestive tract, the peristalsis, the way the whole contrast moves. Is there distension of the esophagus? Is there any hold up of the contrast material at some point? And of course, that is invaluable. Is there any structural abnormality? For example, in this image, is there a kink? Is there any cancer? So all of this is invaluable, and again, um, highlights the importance of dynamic imaging rather than just single time point. If you just give the contrast, just take one image at the end, basically you will only get 5% of the information. So fluoroscopy, um, again, a type of X-ray equipment related radiology. So and remember, because it's X-ray, it's ionizing radiation. So all the principles of patient safety apply on this, and because it is dynamic imaging, there will be more radiation exposure to this patient. Ultrasound imaging is non-ionizing. So we are using sound waves to generate images. And this is a nice scheme of how that image is generated. So essentially what you have is you got a probe which generates sound wave. The sound waves go and hit the target organ and they are reflected back. The same probe picks up these reflected sound waves, and basically there is some clever computer technology, and essentially you will find that on your monitor in real time you will see an image. So yeah, so non-ionizing radiation or no radiation rather. Does the concept of the radiographic density apply to ultrasound? Because of course you're not using X-rays. Yes, they do. And this is a good example of why they do. Although we are taking images with a slightly different technique, but the reason why you can see liver, which is left side of the screen. Can I just check? Can somebody please confirm? You can see my laser pointer, or I'm just confabulating.
Ji, Dr. Najeeb, you can see that.
Okay, so we've got liver. The reason why we can see liver and kidneys separately is that kidneys have got a different type of characteristics in terms of the way it reflects back the sound waves, because there are two soft tissue structures, slightly differing characteristics. You can identify, this area and this interface appropriately. Similarly, if there is a pathology in the liver, for example, here there is this focal lesion in the liver. The reason why you can pick it up is because instead of the normal architecture, there's a different type of soft tissue here. And that really is the reason why you can see stuff on clever radiology. Some of the other attributes for ultrasound imaging, which perhaps are not as easily available in other modalities, is that it provides real-time imaging without the significant radiation burden. For example, what we see with other modalities, one of which we've discussed, which is fluoroscopy. Secondly, it provides Doppler assessment for vessels, which is again an invaluable thing, not easily available otherwise, other than if you give contrast. Nowadays, you can give IV contrast while doing ultrasound, and that actually enhances images significantly in some types of investigations. But by and large, the biggest advantage of doing an ultrasound is that it provides very, very good assessment of soft tissue. And that is really, if you again, information overload is going to happen today. So bits of information which you try to remember is ultrasound is good for soft tissue. What it's not good at is looking at structures which have got high density, for example, bones, because the sound waves just basically can't really assess dense, compact structures appropriately. And rather, the dichotomy is that, in fact, air containing organs are also difficult to visualize because the sound waves does not really travel well in air, or gaseous structures. So they are not reflected back as appropriately as they would be from structures, soft tissue structures. So gut, for example, is difficult to see on ultrasound. Similarly, bony structures are difficult to identify. So based on these principles, those areas of clinical imaging which particularly lend themselves well to ultrasound is, of course, obstetric and fetal medicine, because there's no radiation involved. Um, Again, image guided intervention and biopsy procedures, because you've got real time representation of organs without actually incurring radiation burden. So you can just use it as long as you want. You're relaxed, you're not worried, I need to finish this procedure, otherwise we'll exceed the skin limit for radiation, etc. Vascular assessment, for example, deep venous thrombosis, very, very effectively done with ultrasound. Can't really beat no modality can compete. And again, because soft tissue resolution is so good, abdominal imaging, where we're looking for solid viscera very, very effectively. And also musculoskeletal radiology, where we are looking at subcutaneous soft tissue or indeed soft tissue around joints, also lend itself very well to ultrasound, because you have to basically you need to select a particular probe. And if you select a probe which assesses superficial structure well, then superficial soft tissue, muscles, ligaments, all of this can be seen very nicely. Anyway, so one interesting question: what are the most common ultrasound examination done outside radiology departments? I'm not quite sure if we can get people to answer this question. Can we do that? Shidra, can we get some response from our audience?
Yeah, sure, we can get a response from the audience.
So in the next 20 seconds, I would like you to tell me what is the most common ultrasound examination done but outside radiology departments or conventional ultrasound departments. Shidra, if you can tell me the results in the next 20 seconds, that will be very helpful.
All right, sure. Uh,
Because I can't see the screen. If you're not getting any response, that's fine.
yeah, we're not actually getting any response.
Okay. Let's see if we can get a response now. This is the image which is acquired most commonly. Anyways, I think let's carry on. Echocardiograms done in cardiology or done by cardiac physiologists, essentially an ultrasound. Um, it's been given a fancy name, but that is the contribution to radiology. So we come up with all sorts of new modalities, and then we donate it to other specialties. That's no hard feelings. Okay, touching computed tomography or CT. Again, this implies ionizing radiation. And what you have is you have got a ring of detectors. Instead of just one film, you've got a ring which essentially captures X-rays coming from all three directions. So there will be an X-ray generating equipment, and then there will be a rotary, it will rotate around the patient, and it will produce a three-dimensional image. Because it uses X-rays, it's ionizing, but primarily it is cross-sectional imaging, or it provides 3D representation. Plain radiology or plain radiography provides planar or 2D imaging. This provides 3D imaging, and again, because we use X-rays, radiographic densities are again applicable. What are the different attributes of CT? Obviously, when you start doing clinical work, everybody gets a CT nowadays if they are seriously unwell. But why has CT become so popular? Various reasons. One is that it's quick. It is now widely available. Cannot understand underestimate the importance of an examination being done very quickly. It really provides a lot of information in a very small space of time. The patient don't need to be particularly compliant, etc., etc. And so, when compared to MR, which requires substantial amount of time, CT uses a fraction of time. With regards to body parts which can be imaged, most of the body parts can be, or in fact, everything can be imaged with CT. Some parts of the body are better than other in terms of how they appear on CT. For example, bones are brilliant. You can see fine detail in the bones. However, because you've got soft tissue of varying density in various parts of the body, unless we give good contrast with IV or via oral, we struggle sometimes with soft tissue unless there's a big abnormality. So if you're looking at any soft tissue structure, either abdominal or wherever it is, it's important to remember that you're unlikely to get a good quality radiological opinion unless you give contrast. So CT guided procedures are also possible. Again, one has to be mindful of the fact that CT provides a significant dose in one go. So that has to be taken into account, and therefore, any intervention is usually time limited on CT. Most common examples of such intervention is CT guided lung biopsies, because lungs containing air very difficult to biopsy with ultrasound. So CT comes to the rescue. Um, and you might ask, why can't we use fluoroscopy? The problem with fluoroscopy is, remember, that it is a 2D investigation. It's not a three-dimensional investigation. All the images which appear are primarily dynamic plane radiographs. So if you are trying to target a structure sitting somewhere middle of the lung, you can't really do that. You can only do it with 3D image. Anyways, we'll come to CT at a later time. We'll briefly touch on MRI. Now, MR is also a modality which does not involve ionizing radiation. Instead, the machine has got a big magnet and it applies various magnetic gradients to generate small amounts of currents within different parts of the body. Those currents, or the change in those currents, is basically recorded by the MRI machine and then reconstructed into an image, which you can see on the right side of the screen. This is, of course, 3D imaging. Again, this is cross-sectional imaging. And again, the radiographic densities are applicable to a certain extent, not as much as perhaps on a plain film, but nevertheless, it is visible. So, for example, in this image, you can see that there is a marked difference between the MR signal originating from your ventricles, because it contains fluid that provide a sharp boundary with your adjacent structures or periventricular structures. And even looking at the cortical surface, your gray matter can be distinguished from your white matter on MR, because there is a little bit more fat in your white matter, and therefore, you can easily identify the very sharp boundary along the cortical margin of the brain. Now, if anything disrupts this relationship, for example, there is a ischemia, or there is small tumor, that relationship is lost, and therefore then you can pick up that pathology on imaging. So yes, remembering again, no ionizing radiation, because you know water containing fluid, or sorry, water containing structures like soft tissue have got a much larger gradient induced change in their current. Therefore, soft tissue density is very exquisitely visible on MRI, and that is where it is used to the most advantage in clinical work. Bones, again, there is not a huge amount of movement within the compacted structure of bone in terms of electrons, so they cannot really realign them the electrons based on the MR gradient, and therefore you can't really image bones well unless, of course, there's a big abnormality, but fine details are not visible on MR. Given the way we acquire images, because of the fact, I mean, it's a simple way of understanding why it takes so much time to do an MRI, that the currents involved are very low, and in order to generate a particularly good signal and separate it from the noise, you have to acquire the images for a quite a long period of time, and that brings up its own problems. For example, not a lot of people can lie on a flat couch of 40 minutes, which is a standard acquisition time for complex MR imaging. And therefore, unless, for example, the ward team alerts the radiology team of compliance issues, we cannot really modify the protocol whilst the patient is actually on the scan. It takes a huge amount of time. Therefore, it's very important to discuss these things before the patient presents for the examination. Also remember, the MR is quite a imposing structure. Not all patients can lie in a big donut for 40 minutes. Some of them develop claustrophobia, and if that is the case, then really there's no point in sending them to a close MRI. Some institutions have open magnets and open MRs. They should be sent there. Finally, because of the fact that we need quite a lot of time to acquire these images, these patients or these examinations are susceptible to motion artifact. And finally, because magnets do not really fit well with metal, the any metal anywhere in the human body, or particularly at the point of interest, can um, degrade the images to a point that there's no point, the images become uninterpretable, and basically that's a loss of a slot. So if you are aware that there is significant metal work, then discuss previous to sending or requesting an MR. Also remember that some structures are a contraindication for MRI and can cause significant health problems for the patient. For example, pacemakers are a big no-no unless we know that they are MRI compliant. So most of the pacemakers currently being placed are all compliant, but if somebody had a pacemaker 10 years ago, nobody knows. Need to make sure that it is compliant, because what you don't want is get somebody MR and basically just stop pacing, and you need the crash team in. High yield areas for MR, based on what we've discussed, again, because provides exquisite resolution in soft tissues, neuroimaging. Again, MSK, not for bones, but for joints and surrounding structures, particularly the synovial aspect of joints, ligamentous structure, and the muscles. Abdominal imaging, again, solid viscera, similar to what we discussed with ultrasound. The absence of ionizing radiation makes MR the cornerstone of obstetric and fetal medicine imaging. And also cardiovascular imaging nowadays. A lot of cardiovascular imaging is performed with MR, particularly those diseases where there is infiltration of cardiac muscles, which is very, very hard to pick up with other modalities. For example, CT, because the soft tissue resolution is not that great. Finally, touching on hybrid imaging. So that if you remember, we talked about functional imaging, where we look at the function, and anatomical imaging, where we look at the appearances. And so we divide, these into anatomical modalities like CTMR, and then we've got physiological modalities, for example, what we will be discussing next, which is the nuclear medicine technique, which are SPECT and PET. So why really, with all these fantastic imaging techniques, why do we actually need hybrid imaging? And the answer really is that the conventional imaging, which we have discussed by and large to a significant proportion, which we use in everyday clinical work, is based on appearances or morphology. And we know that in the pathological process, morphology is difficult to pick up in at an early stage, because morphological changes take a lot of time to manifest, and even if they do, a lot of different pathologies may look similar to each other. For example, in the lungs, which brings us to the discussion of nuclear medicine and PET, gamma cameras, conventional nuclear medicine imaging. It's a very, even in radiology, is a quite a niche subspecialist area. So I will try and limit myself to the basics again. And do apologize that if it becomes a little bit boring, but really, the key is to understand what is happening behind the scenes. So when we talk about nuclear medicine and PET-CT departments, they are lumped together because they are using what we call open source radiation material, i.e., the radioactive material which is used to generate images is not confined to a machine like X-ray, CT. The radiation is a closed source radiation. In nuclear medicine, PET-CT, you are actually using radioactive material to inject into patients. And that brings us it significant legislative and patient safety considerations. But again, that is somewhat outside the remit of our talk today. But just for you to remember that you're heading off to your nuclear medicine department, be prepared to follow the local rules, because there are going to be quite a few. And the reason being is it's an open source radiation. So on the left, you have got a gamma camera, which is a camera used to obtain conventional nuclear medicine images. On your right, you've got a PET-CT camera, which is used to obtain PET images. Both of them nowadays, in most of the modern departments, you will have a gamma camera and a PET with a CT attached to it. And here it is. You've got the gamma camera in the front, and you've got the CT component behind it. PET-CT is slightly different. The PET-CT detectors are in the same ring, or certainly not in the same donut, and the CT is just hiding behind the donut. So you can't really see a separate camera head, which you can see on here. But the principle is the same. You acquire both types of imaging, i.e. functional imaging and morphological imaging at the same time. Okay, one very, very quickly, why do we inject, and what is the principle behind injecting patients with radiopharmaceuticals or radiation material essentially what we do, and that apply. I mean, this is a representation of what happens in a PET when we inject, when we are imaging with PET radio tracers. But basically, the principle is the same. What we do is we pick up a parent molecule dependent on what we are trying to image. So, for example, if you're trying to image the spleen, we pick up something which will go to the spleen and stick there. And when it sticks there, its sister companion, which is the radiation emitting particle, will annihilate and produces the radiation, and then it will be picked up by the camera. And a combination of these two structures is called a radio tracer. A molecule or a carrier molecule or something which basically hones down to the site of interest, coupled with the radiation or radioactive particle which produces the radiation. So instead of the radiation coming from a source into the patient and then we generating images on a thing, the patient becomes the radiation source. Basically, wherever there is high concentration of that radiation, that part of the body will be imaged. That really is a guiding principle of how nuclear medicine techniques and PET-CT techniques work. Now, there's a huge amount of difference in terms of the underlying physics of how we obtain images with a gamma camera, with radiation material emitting gamma rays, again ionizing radiation, remember, versus PET-CT, which essentially is a machine which captures photons. But I'm not going to go into too much detail, but that is why the reason why I want to impress that is why PET is called positron emission tomography, and conventional nuclear medicine is called uh, gamma imaging or a gamma camera. Why is it important? Because in 2023, we do not only take two-dimensional images in nuclear medicine, we now take three-dimensional images where we combine, remember, hybrid imaging, CT, with the image obtained from the gamma camera in a 3D setting, and that is called SPECT. And just to make sure that you don't confuse, PET is a different technique, and that is positron emission tomography. SPECT is a slightly different technique using gamma rays and a gamma camera. It's called single photon emission tomography. There is a method to this madness, but I think let's not, you can go and have a look why there's a difference between the two techniques, and it's all to do with physics and the physics of radiation and how positron annihilate and how gamma rays originate from your conventional nuclear medicine tracer. But nevertheless, 3D imaging plus functional imaging or hybrid imaging is not limited to the PET CT camera. It can be done in your conventional gamma camera by this technique called SPECT CT. That is the only thing you need to remember, so that the next time somebody talks about SPECT or PET, you know that they are not interchangeable. They are two different things, although the background principle is the same. So remember, this was your SPECT image. You've got function, and then you've got a fused data set. You can identify where is the abnormality in relation to any morphological abnormality, for example, on CT. Later on, we're going to look at a few cases where I'll demonstrate why this is so important. Very, very similar looking images on PET because you've got a CT, you've got a functional image, essentially originating from the radiopharmaceutic or the radio tracer which you have given. Nowadays, most of the PET-CT imaging is done by what we call fluorodeoxyglucose, which is a glucose analog. Basically, That is why you can see so much tracer activity in your brain, which is the highest consumer of glucose. But also remember, all the badness in your body, like cancer, like infection, requires one thing, which is sugar. So if you want to image pathology in your body or active pathology, you need sugar. And that's why if you're heading to a sweet shop, just try not to overindulge in things because it promotes badness. Anyways, so nuclear medicine summary: ionizing radiation, again significant amount of radiation burden because you are actually injecting radiation into patients. They are going to be exposed to it for a hell of a lot of a time until they completely excrete it. A huge amount of patient protection and things required. Uh, so nuclear medicine is a discipline in itself and can be used in any body system. You can do renograms, look at how the kidneys are functioning. You can do ventilation perfusion scans to see if there is any clot. Nowadays, CT, pulmonary angiograms have pretty much made VQ scans obsolete, but two scenarios where it's still required. One is when the patient is pregnant and or a lactating breast, whereby the dose to the breast is significantly high in CTPA, and it's easier to actually do a low dose ventilation perfusion scan. Second scenario is when the patient is allergic to contrast. They can't really have a CTPA. If you can't give contrast, you can't really do a pulmonary angiogram. And so that is one another type time when you need VQ scan. Similarly, the most common investigation is bone scans, but it's not limited to basic. You can do anything. And remember, one thing which I'm going to touch is hot and cold nodules because it causes a huge amount of controversy and confusion when we are either doing exams or we are talking to colleagues. And there's a reason behind it, and let's see if we can clear up the concept. Now, unfortunately, this vocabulary of using hot and cold nodule is a misnomer, basically, because in a lot of nuclear medicine investigations, it's not applicable. But let's have a look at this example. This is not my case. This is one of the case reports which is referenced below. What you can see on your CT, or this is a coronal CT image, you can see there are two abnormalities in the thyroid gland. Yeah, there is a problem in the right lobe, right arc, and then there is another problem in the left lobe. Okay, so when we do nuclear medicine imaging in this patient to see the function, so we have seen the morphology. As you can see, morphology is not really able to differentiate between the two based on appearances alone. So we go down the route of functional imaging and we do a nuclear medicine investigation. And we identify that the abnormality in the left lobe of thyroid is hot, i.e., it is taking a tracer or radio tracer which we have given to the patient. The contrary, the abnormality on the left side is cold. It is not actually actively taking tracer. And the tracer which we use for thyroid most of the time is iodine based. Essentially, what this functional imaging component is telling us is that the cold nodule is not functioning. It's not functioning thyroid tissue. Hot nodule actually is functioning thyroid nodule. There is function. It is just that it is functioning more than we want it to function. And that is really an important observation, because the cold nodule in this instance is actually the cancer, because it has replaced normal thyroid tissue and it turned out to be papillary thyroid cancer in this patient, whilst the hot nodule was just basically a little bit of an adenoma of the thyroid. So the cold nodule, one would have thought if there is some abnormality of pathology, which is hot, it's bad for some reason. But actually, that is not the case. So I think we need to replace this hot and cold nonsense with just a more simple and more effective terminology, which is that for abnormality taking tracer, is it tracer avid or it is not avid? Because if you remember, if we are using PET, then a hot nodule will become actually pathological, which means that it is consuming a huge amount of sugar, and if it is an abnormal tissue consuming a huge amount of sugar, it is cancer. So therefore, don't get confused between these nomenclature or terminologies. Just try to get your concept clear that it's either tracer avid or it is not tracer avid. Dependent on the tracer itself, if it is tracer avid, you can um identify pathology. If it is, but depending on what tracer you have used. So I hope that this little bit of discussion will come in handy in any of the future exam like scenarios where these questions are very common around hot and cold nodules. Yeah. So remember that thyroid is a little bit different than other areas. Anyways, coming back to other types of investigation, the nuclear medicine in bone scan is very common, very commonly used for skeletal staging of malignancy, because it's a very, very sensitive test. If you've got an abnormal part of the bone, manifesting it of CT or plain film takes a huge amount of time before it actually causes significant destruction. Basically, it's too late. On functional imaging, you can pick up these very small abnormalities, a very, very early stage, and therefore that provides significant benefit. Um, the other is not limited to cancer. You can look at infection, particularly, for example, around joint replacement. Renal, another very significant component of nuclear medicine imaging, and just to show you that dynamic imaging provides significant amount of information above and beyond what you can just see on morphology. This is an example where patient has had a renogram, the appropriate tracer was injected into the patient, and then the patient was on the camera, and we could see the whole tracer journey, concentrating in the kidney and then getting excreted from the ureters into the bladder. And essentially, we can draw a curve demonstrating that the excretion of this tracer on both sides is completely normal. There is no evidence of it. For example, in this case, we might have done it because is there obstruction. Now, there is a little bit of a difference between the two side here. The tracer completely clears from the right ureter, the left ureter rather. Here there's a little bit of a dilated component. So there may have been some previous obstruction here which has now been relieved. But essentially what is happening is, what we can't see is significant amount of tracer accumulating and dilating the system. There's probably a delay in coming out, but there is no obstruction. And this kind of information is not available really with any of your morphological imaging. Just a pictorial representation of VQ scan. I'm not going to go into too much detail, but a very, very interesting concept, which is what we do is we do two parts of the study. We give a tracer, which basically, identifies the air-filled areas of the lungs. So, for example, here, this is the ventilation part, and then we inject a tracer via the blood vessels, and that goes into areas which are perfused in the lung. Essentially, what we're trying to do here is, if there is a pulmonary embolus, the tracer will not get there. There will be a big hole. However, obviously the air will be getting there because the bronchi are patent, and then there will be a mismatch. There will be no tracer in that particular part of the lung on your perfusion imaging, which is through IV. But there will be tracer visible on the ventilation part, and that clinches the diagnosis. So yeah, different tracers, different time, and you can compare two different functions of the body part. So I promise this is coming to an end. If you just bear with me, we're just going to quickly look at PET-CT imaging. There's some interesting images coming up if you are going to be asleep. So hang on. PET-CT again, open source ionizing radiation, all the bells and whistles of what you need to be aware of. It's just the most important different pathologies whereby we are using PET-CT. Of course, we're using it for cancer. We're using it to identify infection and inflammation, can requiring sugar, for example. So that goes down to the most popular PET-CT tracer, which is fluorodeoxyglucose. But we are also using other tracers to do other imaging. For example, we can do perfusion imaging or cardiac imaging with PET. And one very upcoming area of imaging with PET is dementia imaging, because if you can see an abnormality in the brain on morphological imaging, it's already too late. The damage has been done. The morphology has irreversibly changed. Can't really do much about it. However, if you can identify a, a biomarker or marker of abnormality with functional imaging at an early stage before actually the architecture is destroyed, then perhaps you can stop that process. That is just why developing these techniques, particularly in dementia, is very important, because once it sets in, we can't really reverse it. So it's better to find a way of identifying it at an early stage. So why is PET-CT so useful, or hybrid imaging so useful? So this is an example, clinical indication, adenocarcinoma or cancer of esophagus on your endoscopy, and the CT does not appreciate tumor. Further staging required. And here is the image. You can see on the left side your CT image, and you can see the PET-CT image, and you can see that there is a hot area at the junction of the stomach with the the esophagus. This is not This can not be easily called as abnormal on CT because it is collapsed. And remember the concept of radiographic densities. If you've got a soft tissue structure which is collapsed, there is no interface. For example, in the lumen, you can't really say if there's any bad things happening here, or there is a change in things. However, with your PET component, you can see that there is hot, so there is an abnormality, and therefore this is the area of cancer. So this is how we get the best out of both worlds of physiology and anatomy. Remember that anatomy is important nevertheless, because if we only look at the functional part of the PET, sometimes we cannot identify where the abnormality is in relation to the patient's organs. So we can't underestimate the importance of the anatomical component. And another example here, somebody who has had metastatic cancer of the lung, which went to the liver. This was the first scan, and it showed this area. Really can't see very much on the CT because just haven't destroyed the normal liver enough for it to become apparent. Again, going back to our radiographic density principle, it's just not destroyed enough to stand out from the normal liver architecture. Here it is becoming a bit more, but there is definitely much more uptake or thought uptake here on the follow-up scan or second scan, and clearly there is unequivocally progression in this disease, which is very difficult to call on the CT alone. So areas where either the pathology has not progressed significantly to manifest itself on morphological imaging, or it is very small below the resolution of imaging, the hybrid functional imaging becomes particularly important. And I can assure you that in the next couple of decades, it is going to be much, much more in use. And again, the final example here is that somebody has got malignancy in the tongue base on the right side, which was then operated, and therefore you can see there's a little bit of asymmetry of where there has been a graft, but there is unfortunately a residual disease here, which you would probably have found it difficult to pick up with CT alone or MR alone. So the final few slides are somewhat non-academic, and they are more to do with your um, management or people management type of situation. Um, and the idea really for that is to institute early in your mind that you know radiology is on your side. It is not you against them. Have to work as a team. And there are some ways where you can develop a good rapport with your radiologist or your radiology department. So just go through some of these things. One is that, for example, if you want to order a scan, it's a little bit, you know, uh, not ideal. You can request a scan, which is always better. Writing please on a request card always work wonders. Remember, you are dealing with human beings, and all the human characteristics are going to be visible on that relationship. But always remember that a scan is a scan. If you're going for a scan, you will find a CD or a plain film at the end, which is fine if that is what you want. But if you really want an opinion, or you want a radiologist to help in clinching the diagnosis, then you have to um, develop a rapport and justify and contribute equally as equal partners in getting that investigation done. Why it is so important? Because at the end of the day, the whole radiology cascade starts from your end. You are requesting, if you request the right modality at the right time for the right patient, you are going to get the best results at the end. And therefore, understanding of the various things which we have discussed is so important. Don't underestimate developing a good relationship with colleagues in radiology, because they will be an invaluable resource in your day-to-day clinical practice. It's just a summary of the thought process which should be going in your mind when you're requesting things. Is your patient compliant? If you're sending them for an MR, going to be okay. Do you have to give them pain relief so that they don't jump out of the bed in the middle? Are they confused or demented? Do they benefit from a bit of sedation? Have they got good venous access so that nobody is calling you from CT? Look, we can't really do this because we can't inject contrast through a venous access. Without contrast, most of the investigations become meaningless. Remember history of any contrast allergy, which needs to be written down in request cards. Any problem with renal function, which is particularly important for iodinated contrast, which we use for CT imaging. We already discussed about pacemakers and all the rest of it. Um when you're selecting a modality, you need to understand, what is your local environment, your institution, availability of various types of modalities, how quickly you need it. You know, it may be that you want to image the brain, but you are doing it in a trauma setting. Therefore, you need to do it urgently. Therefore, a CT in this situation is going to be better than MR, even providing for the fact that MR has got a better profile in some of the indications for doing a imaging of the brain. Similarly, some of the modalities are best used as first line of screening tools. So, for example, in the context of trauma, you can easily use CT head because it will give you information about fracturing and presence of blood in the cranial cavity, etc., etc. The fraction of the time than an MRI. If you find an abnormality in your first line of imaging, then you can always go down the route of more complex imaging. So, for example, if somebody presents with shortness of breath, don't necessarily need a CT initially, can do a plain film, and that would give you a huge amount of information. Then you can decide whether you want to do more complex imaging. Finally, the couple of things which are again a bit of pearls of wisdom rather than any academic value. Remember, radiology is part of your clinical workup. It does not replace your history taking and examination and overall clinical expertise. The reason being that I've been singing praises of all modalities, how amazing they are and how amazing they perform and things. But the bottom line is that radiology findings can be non-specific. And I'll give you an example of that towards the end, the final slides, why this non-specificity can cause problems and why clinical acumen cannot replace radiology anytime soon. Remember, we all get excited. Oh, we need to learn looking at X-rays. We need to learn looking at abdominal films. We need to learn looking at CT head. Fine, please learn. But at the end of the day, if the image is of suboptimal quality, no matter how good you are in interpretation of images, you are not going to get any joy out of it. So, um, time invested before sending the patient for an investigation is probably the most important component. If you invest time in sorting out the logistics and things which impact on your image acquisition, you are going to find much better imaging, and that is, I'll give you a very simple example. A lot of patients present to A&E departments, and the patients have got a question mark of pulmonary embolus, but they have got other, things wrong with them, and the patient is tachypneic. They're breathing very fast, and everybody wants them to have a CTPA. But what I keep telling my colleagues that if you send me a patient who's breathing 100 beats a minute, the CTPA is going to be meaningless because there will be so much respiratory motion artifact that I can almost write my report even before doing the CTPA, which is, and unfortunately, not really exclude PE because of significant motion artifact. Stabilize the patient if at all possible. If there is other pathologies happening at the same time, try to, manage them first before going down the route of a particular modality, which we know can be affected by things which are happening with the patient currently. And finally, sometimes the most important investigation is the one which happened in the past. Why is that? Because what we are seeing in the current investigation is meaningless if we do not have anything to compare against. But one example is a pulmonary nodule. We've seen a 1 centimeter nodule. No idea what this is. No radiologist can tell you what it is. Is it a cancer? Not a cancer? Don't know. However, if we had a CT 6 months ago and that nodule was 5 millimeters and it's become 1 centimeter, basically that means it is cancer until proven otherwise. And so the investigation done 3 or 6 months ago actually was more perhaps important than the investigation which was done now. So remember, encourage your patients to keep hold of their previous investigation. I cannot stress it enough, and always take it to any institution they are being imaged so that the reporting radiologists can compare. It is just so important. Why is clinical acumen so important? Because, whilst radiology can give you an answer in quite a few cases. For example, on the left side is a pneumothorax. We all know, that is, there's no doubt about it. It is a pneumothorax, full stop. But what is happening on the, and again, okay, very last time I promise, radiographic densities. Okay, here we have got a normal lung, good interface with the chest wall, fine. Air is entered into the pleural cavity. It's purely air, nothing else. In lungs, you've got all sorts of things like soft tissue and vessels and water and what have you. This is purely air. There is a sharp demarcation here. Therefore, you can see this abnormality. And it is black. It's not stopping any of the x-rays. Anyways, so this is conclusive. This is not conclusive. I have no idea what is. I can describe what I can see. There is a huge amount of interstitial abnormality, but I don't know if the patient has got pulmonary edema, or they have got interstitial fibrosis, or they've got some funny infiltrative disease like sarcoidosis, something like that. So I can give you a list of 10 things. At the end of the day, what you have to do as clinicians is that you have to hone it down to the most likely possibility based on your clinical examination, your history, your bloods, and other diagnostic components. So remember, radiology in a lot of instances is going to be non-specific. Cannot replace your clinical acumen. Anyway, so I think I do apologize. I think I've taken more time than I wanted to from your Saturday, but I hope that whatever I've said has been helpful. My aspiration is to do some more tutorials. Today was all about the very, 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 very basic principles of radiology, the huge amount of things which we have had to cover. So I can only skim past very few, basic things. Hopefully, in the future, we may be able to do more bedside, interpretation type scenarios, or look at some case examples where different modalities have been performed better than others, and can have a more interactive discussion and things. So, thank you for being for your attention, and more than happy to take any questions.
Covered pretty much all questions from the audience side. I would like to ask you a question myself. How did you get connected to PWA in your med school, and how do you think PWA has helped you in your career and professional life?
Wow, you saved the most amazing question for the last, isn't it? Yeah. No. So PWA, मैं जब मैं फर्स्ट ईयर में था तो went to the drugs. उस जमाने में ड्रग बैंक होता था, तो some of our class fellows went to the drug bank, and I got to know quite a lot of seniors. And I was just completely, amazed as to the amount of work which was done and the way selflessly, our peers were helping patients, and the rich history of the organization. And of course, Dow Medical College was, quite different in the late 90s. So there was, quite a lot of pull towards going to PWA and spending time rather than malingering around in the college. And but essentially, in a summary, it was my peers who draw me. जो seniors थे उनकी वजह से I was associated PWA, and it has been an amazing association for the last 23-24 years. When I came to the UK, the best help I got was from our PWA seniors. And the time when I was applying and struggling, there was a lot of comfort and support coming from seniors. And I think that really underpins the whole concept of peer support. And with an organization being around for 44 years, it just provides an amazing resource in the background, which can be tapped appropriately. So yeah, I mean that's what my journey has been with PWA.
That was really wholesome to hear. Um, I'd like to thank you, Najeeb. I thank you so much for joining this session and for such an informative session. It was like really nice to hear, and I'd like to thank the audience too for being such a good audience, for being very active and asking questions too. So, if there's anything you would like to say at the end, so like we can then conclude this session.
No, thank you very much. I hope that it is helpful. I am aware that it was perhaps an information overload, quite a lot of things to cover. But nevertheless, I think we have to start somewhere. I'm hoping that we will perhaps do a session which is going to do more about individual modalities and perhaps a little bit of training around looking at some basic investigations like X-rays and abdominal X-rays and things. So, you know, keep tuned, basically.
All right, Jazakallah. Thank you so much, everyone. It's officially, I think we're officially done for this session. So, thank you, everyone, for joining.
Allah
Allah
Hafiz.
Hafiz.